Anytime you like.
Okay, welcome to the Issaquah Senior Center Learning Lab series. We're so glad you joined us for this learning experience. For the month of May, our goal is to invite experts to share their knowledge of COVID-19 related topics that will help you navigate these challenging times more easily. Today, I'm pleased to introduce Christine how do you say your last name again? Somradian. On the topic of testing, treatment, and surveillance of COVID-19. Christine is a regulatory strategy and compliance evangelist consulting on quality process and technical solutions for the medical and health industries. Christine also lectures at the University of Washington Graduate School and across the country. So take it away, Christine.
Hi, everyone. So I hope you're all faring well in continued lockdown. We all kind of adjust to this new reality. I do need to share my slideshow, and I need a moment of help from you. So I just do share screen, Catherine? Is that the best way to go?
Yeah, you should be able to.
PowerPoint slideshow. There we go. That's the one I think I want. Okay. So I know that not all of you have the ability to see this presentation. So I am going to talk through it, but I do like to have my slides just to kind of help us along here. Can everyone see the slides now?
Yes.
Wonderful.
Not everybody.
Okay. All right. Okay. So yeah, I'll be talking through. Okay. So I first want to just talk for a moment about what the different words mean, right? So there's a name for the virus and there's a name for the disease. And the actual virus was called the novel coronavirus of 2019. And novel meaning new. And because it's related to another condition they observed in the past called severe acute respiratory syndrome, or SARS, the virus got named SARS-CoV because it's a coronavirus 2. And that's because it's the second SARS coronavirus that they've identified. The first one was back in, when was that? 2002. And so severe acute respiratory syndrome, SARS coronavirus 2 is the big long name, right? And the disease, on the other hand, is called COVID-19. So that stands for Coronavirus Disease 2019. So just to help, so when you hear people talking about things, everyone calls everything COVID-19. So when you get a test, for example, we're going to get into this, you're not actually getting tested for COVID-19, you're getting tested for SARS-CoV-2. If you get sick, then that's COVID-19. Okay. So here's a little picture that I have of the actual virus, just to show you what it looks like. It's lots of little proteins, and it also has a lipid membrane. And and inside you'll see there's a nucleoprotein. There's a kind of like a beaded, it's like a string of pearls, if you will. And that's the RNA. And so this is an RNA virus, and it infects people by transferring its RNA to another cell. As opposed to there are DNA viruses. And I'm not going to get into virology right now, but just keep that in your mind. There's RNA viruses and DNA viruses. Okay. So this is an RNA virus. So the little lipid membrane is actually important. So wait a minute, let me back up for a second. So if you'll see that there's a protein that sticks off the very edge of it called the spike protein. And that's the one that we're going to talk a little very briefly about the vaccine. I'm not a vaccine expert, so we're not going to get much into vaccines. But that is what they're making the vaccine against, is that spike protein. Okay? And then there's other proteins, you know, the envelope, which is basically, you know, surrounding the entire virus in different segments. And then there's the membrane protein. I said that one. The envelope protein and the membrane protein. But the most important part at this moment for people to know is it does have a lipid membrane, and it is a lipid membrane virus. And why that's important is that's why hand washing is so effective against this thing, because when you use any kind of a soap has these characteristics called surfactants, and it breaks up lipids. Just as it breaks up grease on your dishes or on your hands, it breaks up other fatty things too, including the membrane of the coronavirus. So if you wash your hands really well, you're actually getting rid of the coronavirus and killing it in the process. So I'm going to talk about testing really quickly here, because there's a lot of confusion around testing. And there's basically 3 types at the moment of lab tests, okay? The first one is the nasal swab that they stick up people's noses, right? And that's called an RT-PCR, and the long name is reverse transcriptase polymerase chain reaction. So polymerase chain reaction is a technique that they use to do a laboratory analysis, basically. And then they amplify it. So there's something called nucleic acid amplification. And that just means that they kind of like you amplify a signal to get sound out of a speaker. They have to amplify the presence of the virus to be able to test it. So that's what that means. That's what we've been using from the beginning. And those tests got stood up very, very quickly. Most of those tests are pretty high quality, not all. But the technology is pretty standard, let's put it that way, for how they made those tests. The variation comes in things like whether the person swabbing you is swabbing in the right place, whether they're using good swabbing technique, and also how much viral load you have in the places they're swabbing. So there's been a lot of discussion, and I'll say controversy, around whether swabbing, whether the nasal cavity, the upper nasal cavity, the nasopharynx is in fact the very best place to swab or not, because they have had some luck with swabbing people who are sick in their throats. So that's ongoing. Hang on, I'm gonna shut a window. That's kind of an ongoing controversy, and there's more and more data coming out, and it's going to get clearer over time. But that's what that's about. So we know that sometimes they're seeing false negative tests on people who are sick for coronavirus, and it's usually because of this thing about viral load. Also, some people just don't have a high viral load is another factor. So the next kind of testing is the one we've all been hearing about in the news, which is serology testing, or serologic immunoassay. And that's where you're looking for the antibodies against the virus, against the SARS-CoV-2 virus. And the first one is a nasal swab. The second one is the blood draw. And at the moment, the most reliable test is a blood draw from venous blood, and they spin it down and they look for your antibodies. There is a version that's on the market that's at the moment not terribly reliable, and that is the finger stick, where they can do from a drop of blood. And there's 100 different reasons why that's not reliable, and it has to do with the fact that they're getting blood from your finger and the technology involved in that and the ability of detection. So I'm not going to go farther into that, but just know that if you know someone who's getting a serology test, they should probably get a venipuncture. And the best, most reliable one, I think I have a slide on this. Yeah, I do. Is the one that they're doing at University of Washington right now. It's made by Abbott. The third one that's kind of coming along is what's called a direct antigen test. And that means that in blood, I think is the method that they're doing it, they're looking for the actual virus, the actual antigen, that spike protein in the virus, rather than using the amplification and the PCR chain reaction, okay? So that's just coming onto the market. The tests aren't very reliable yet. And so if you're gonna get tested for if you have it or not, it's probably the nucleic acid, the RT-PCR test that's so famous right now. So here's just a little, I'm gonna give you guys these slides, and this is just for the science geeks in the audience. I don't know how many of you studied science, but that's an example of how you do RT-PCR. And the slide deck will come later to you guys, and you can look at this to your heart's content. Okay, so next, let's see, I went the wrong way here. So here's an example of, this is a picture from Abbott, actually. This is their picture describing how the testing works. So it's a nice little informative test. The little Y-shaped thing in the middle is kind of the shape that the IgG antibody that they're testing. All IgG antibodies have that shape. So it's just kind of showing you, what the antibody looks like, and kind of giving you an idea of what the process looks like to get tested for the serologic test. I thought that was just a nice, simple slide. Okay. And the real issue we're having is that FDA normally has very stringent rules for getting test kits onto the market, or tests, and they're called IVDs, in vitro diagnostics. That's the term used. And they get a lot of data normally from each manufacturer before they allow them to put the product on the market. And that data involves really extensive testing where they've you sort of beat up the assay. You test it under different conditions, how the reagents, the chemicals involved, how do they perform at different temperatures and on different machines. I mean, all kinds of these kind of scenarios, if you will. And that's the normal process. Well, we're in a situation now with coronavirus that there's an emergency status, and they have a pathway for that, and it's called an emergency use authorization, EUA. And that's how most of these tests now are getting on the market, because they had to do something. They had to give people a break, right? They couldn't ask for the normal amount of data, or it would have been a year before you had any tests at all, right? So at some point, FDA was under a fair amount of pressure, and they were allowing additional test kits being imported from other countries that had not been through the EUA process here. And I've been reading recently that they are pulling back on that because there have been some spectacular failures in some of the test kits. And this is even the PCR, RT-PCR tests for the nasal swab. There was a couple of tests coming out of China. Italy bought, 100,000 tests, or maybe I think it was more like 500,000 tests, and so did Spain from this one company, and they had a 40% false negative rate. That's really scary. If you're using the PCR to test whether people have the virus or not, and 40% of the negative tests are wrong, and they do have it, that's a very scary proposition. So recently FDA has been pulling back and saying, no, you cannot use imported tests unless they've been through the EUA process. So, but even under EUA, we have about 150 COVID-2 tests on the market right now, SARS-CoV-2, and that includes both the PCR test and the serology test. And even among those, there are some recalls already happening because the tests aren't working as promised. So the EU is an interesting thing, and the last thing I'll say about it is it's very interesting because when you do an EUA, it says, okay, we want to get on the market and we're going to promise you to give you rigorous data, but will you please let us on the market right now with some initial data that we have? So they'll give them their initial data, and then they'll say, we promise to give you more data. And so sometimes that doesn't pan out, right? And that's, I think, the scenarios we're seeing with some of these recalls. So there's another topic happening called point of care testing. And point of care testing is mostly the serology test, and it's where the finger stick is happening. I've heard of a couple of point of care PCR tests where they use the swab. I haven't heard much success about those. I'm not going to go into that. Now that you know the term RT-PCR, if you're interested in that, you can certainly Google it. But there are some tests coming up for the serology. They're under EUA. They're on the market. And their profiles don't look that great yet. And a lot of that's because when you do finger stick blood, its properties are just different than venous blood. Venous blood is kind of like the gold standard. It's the purest blood in the body. Everyone knows how it behaves. And, we know about the interfering proteins and all that kind of nonsense. And with the finger stick, it's a lot more complicated to get a good test. So that's the main issue. The other two issues about point of care testing is they use them in places like small clinics and things where people running them are like nurses' aides, right? So a nurse's aide has what? 1 year of junior college training to be a medical assistant. And they're not really qualified to even have the instincts to know what you can do and what you should do and not do, right? I mean, aside from what the directions say. So the directions, of course, are important. And on these tests, they do try to keep it very, very simple. But even so, there's always problems. But it is much more convenient, to be able to test people at a clinic, and then even the home test kits. Now the home test kits seem to be both home swab, which is just coming onto the market, but in that case where there's a swab, they're sending the swab off to a lab to be analyzed. You're not analyzing the swab result in your home, but they are doing a drop of blood one, kind of with the same idea of a blood sugar check, right? But with a bigger device. And so there are home test kits coming along, but people don't know how to, there's like, you know, even when you do a finger stick, there's collecting a sample and there's handling the test items, and how you do that affects your test results, right? And a lot of people, you know, don't have very high level reading skills for a variety of reasons. So I think they say that on average for home test kits, they assume a 5th grade reading level. And so you just kind of have to keep things very simple for people. Regarding serology tests, there's a real challenge afoot, and that's that because this is such a new virus, they don't really know yet about the immunity. You know, so if you get COVID-19, or if you're infected with the SARS-CoV-2 virus, either way you want to put it, and you mount an antibody response, right? And they are learning that there's great variation in how people mount a response. And it looks like at the moment from the data that the sicker you are, the more of an antibody response you mount, but there's a caveat to that, as long as you have a healthy immune system, right? So if someone gets very sick and they're immunocompromised, they may not mount much of an antibody response. And that happened somewhat in China, and that led to a paper that people are still arguing about, which said, well, you can get reinfected. Okay, so that's still getting discussed. So in other words, if you get sick and you mount an antibody response and you test positive for the antibodies, can you catch it again? You know, that's the $1,000,000 question, right? And so the way they put that in science terms, it's not yet known whether antibody presence correlates with longstanding protective immunity. So we don't know. And then, I guess it was late last week, we had a report off one of the Navy ships that there are 3 sailors who were reinfected. In other words, they tested positive for coronavirus, SARS-CoV-2 before, and they appear to be having it again. What we don't know is, does that mean that they got sick again? Or does that just mean that the virus showed up, right? So if you're doing a nasal swab and you're in close quarters, like a Navy ship, and of course you could come across it again. But what we don't know is, just because they came across it again and it's showing up in their nasal passage, does that mean that they're going to get infected? And we don't know that yet. So people should not freak out about that result. I've been hearing some freaking out about that one, but you have to pay attention to what they actually said. Okay, now I'm going to talk about disease surveillance for a little bit. So disease surveillance, what is that? It's an epidemiological practice by which the spread of disease is monitored in order to establish patterns of progression. Basically, they want to see where does it go and who does it infect, you know, and track all that, right? So we're really, really relying on disease surveillance right now. That's how we know what's happening. There's a lot of different methods for doing disease surveillance. I'm not a public health expert. I know enough about it to be a little dangerous. But mainly what we rely on is case-based reporting. That's where local and state agencies, so the local, in an average state, the local agencies report to the state agencies. When I say agencies, I mean public health agencies. So the local ones report to the state, and then the state reports to the CDC, and then the CDC reports to the WHO. Is sort of the progression for how this goes. Then there's another type of surveillance. It's called global surveillance, aggregate data reporting. So case-based reporting means that there's a health provider involved and they've identified someone that is sick with the disease, okay? And then global surveillance is sort of a more broad stroke approach where they're looking at bigger numbers and other indicators in addition to case reporting. So global surveillance can have case-based reporting, but in a lot of countries, you don't have the level of sophistication of a public health system that we do here. So they have other methods that they use. I'm not going to get into that today, but they use other methods. So collectively, that's considered aggregate data reporting. So then you have serologic testing, right? So serologic testing is not about sick people, right? It's about who's positive for the virus. And that's what we were talking about earlier. And then there's contract tracing. So contract tracing means once you've identified a case or you've identified someone who is seropositive or serologically positive for the virus, you want to trace who they've been in contact with. And countries that have had great success with that, first is Italy. I mean, it's one of the reasons that they've flattened their curve, as they say. And can you all still hear me? I'm having some internet issues. I just saw that. Okay, great. In Iceland has had fantastic success. I mean, it does help that they're an island, but to be honest, they got on top of it very, very fast. And they started testing everyone for the RT-PCR test. And then when they had serologic testing, they started using that too. And they've been really rigorous about contract tracing and then asking people to quarantine when they are identified as a contact or they've identified as seropositive or they have a case of coronavirus, right? So their numbers are remarkably low. So that's a pitch for doing contract tracing, which we're going to be getting into in this country. Okay, so who's who and what's what? So there's the World Health Organization, and they provide guidance on global surveillance for all nations, guidance on preparedness, readiness, and response activities. And they also serve as the coordinator and the clearinghouse for all clinical studies around the globe of COVID-19. And let me tell you, so I have a kid who's a physician, and she works at a hospital in Eastern North Carolina, and just that one hospital, and they're not one of the giant, well, they're a pretty big hospital, but they have 3 studies they're doing right now, kind of on how does this affect COVID-19 patients? How do they recover with this therapy? What does the profiling look for this issue? So every single hospital, certainly academic hospitals around the country and around the world, are running clinical studies right now. I think we're up to the thousands right now. So World Health coordinates all of those. It gives them sort of a place to come put their data and to kind of have an ongoing indexing of all those studies. So this is what World Health Organization recommends. They recommend active case finding and testing, aggregate reporting as a stopgap only. So remember when we talked about global surveillance and they said case reporting is better, and so serologic testing by default. So they think that only do aggregate as stopgap. So when the countries have a poor system in place. And contract tracing in all transmission scenarios, which means whether you have a seropositive test or you have a RT-PCR positive test or you're actually sick with COVID-19, they think that there should be contract tracing for all 3 of those. So this is a snapshot of the Johns Hopkins website. If you just Google Johns Hopkins coronavirus, you will find this site. It's become easier and easier to find by the week. So Johns Hopkins is in Baltimore. They're a very famous university here. They have the #1 public health school in the country, without question. And they've been the disease tracking headquarters for years. And so that was nice because they were kind of ready to go pretty quickly with standing up a dashboard for this. And they're getting data from different sources, but they're probably the most reliable. Some days you'll see some other sites reporting a little ahead of Johns Hopkins, but I think that's just about their vetting and clearing process that they kind of, they want to look at their data. There was a hack that happened, I don't think it was John, it was another website where somebody hacked the Pakistan data and they changed all the case numbers. It got detected and fixed pretty quickly, but that's kind of part of why they try to vet their data before they stand it up. And it's an ongoing I think they work 24 hours a day. They have different shifts and all these things. And they also use a lot of data intelligence and artificial intelligence, right? That's available now. So yeah, this was from last night. 4,806,299 cases in the world right now of coronavirus. And we are far and ahead above everybody else. We have 1,508,957 cases as of last night. Okay. Okay, so there's a bunch of different data model sites. I love this quote that's been around for decades from a very famous statistician in Britain named George Box, and he said, all models are wrong, but some are useful. And this is an important thing to know, because as you watch the news, you'll hear them talking about different disease models and different data models. And whenever someone makes a model, it's just like any other science. They're asking a hypothesis. They have a hypothesis that they believe is true, and they're trying to use the data collection to determine if that's correct or not. And so, for example, IHME, the Institute for Health Metrics and Evaluation, that's here, that's getting used nationally and internationally. They have a long history. Before coronavirus, I actually know people who work there. They did a big study last year called the Global Burden of Disease, and they've done many other studies. They're very AI driven, and they take in data from every health reporting agency in the world that will talk to them. Kind of in tandem with World Health, they have a different function. They're modeling the data. They're not creating health policy, right? But they, have changed their model massively at least 3 times now based on assumptions. So one of the assumptions was about stay at home, so the early model they had for the US was really promising and had really low death rates. I think their model in the beginning was 60,000 deaths. Well, they were assuming that when a government made an order, they assumed, first of all, that the US nationally would have an order coming out of CDC. Then they assumed that each state would have an order and that everybody would follow it. Well, we didn't do that. So those numbers that they gave got completely blown out of the water. And now when you go to their website, you'll see very different assumptions that they're making, and they have different models. It's an interesting site to explore. You can just Google them, right? I didn't give links here, but you can just Google them. Institute for Disease Modeling is stood up by the Gates Foundation. So that happens to be across the lake in Bellevue. And I'll talk about why do we have all these people here in a moment. But that's another very interesting set of data models, and they're different, and they're asking different questions, right? They're answering different questions, and they're forecasting different things than IHME. Then you have the World Economic Forum, and their focus, of course, is on the economy. And they have some very interesting models too. And so they're definitely worth checking out. Okay, so then there's the CDC. So the CDC is the official clearinghouse for all domestic public health data in the US, right? So they provide a surveillance resource center, and it gives guidance developed by CDC and partners. So they take guidance from others, and that includes World Health. For improving the practice of surveillance. So they have they have a set of interactive databases, they have methods they list for doing disease surveillance. They have a lot of rich content on legal, ethical, and policy issues, and they also provide for especially small public health agencies, and also sort of academics as well. They have tools and templates. So I'm going to talk for a while about why do we have so many wonderful health agency health data intelligence companies here in the Puget Sound region? Well, that's because we have an absolutely stellar global health program at UW. We have a very stellar infectious disease program. In fact, in terms of infectious disease, we're probably ahead of Johns Hopkins for that subject, okay, that specialized topic. And because we're so advanced and there's so much good stuff happening here, they attract amazing people. So, it's just kind of like you have Microsoft here, so you have a lot of great software companies, right? Well, we have, global health here. So that's why IHME has their headquarters here. It's why IDM has their headquarters here. And it's why we are exceptionally lucky to have Jeffrey Duchin at King County, Seattle Public Health. He is amazing. He came from CDC, by the way. And we're very, very lucky to have him. And I'll tell you right now that he's probably advising the state public health department more than they're advising him. And I'll just leave it at that. Virus treatments. what's going on with it's treating the virus. And I didn't do much on this. We can talk about it more, but it's been changing. Like literally every day this has been changing, but I can break it down into 3 categories for you. There's antivirals, and those are drugs that inhibit the virus's development and replication. There's immunoglobulin, and there's antibiotics. Now, there's also a couple of other treatments where they're treating the effect of COVID-19. And there's a lot of drugs on trial right now. And actually, I don't work with drug makers very much. I work mostly with medical device companies. And so I do have friends who are in the middle of drug trials. So basically, the entire medical community and the entire biopharmaceutical world, it's kind of like throwing spaghetti at the wall and seeing what sticks. That's the phase we're in right now. Everybody's thinking, okay, well, this drug gets used for this thing. Does it relate to something that they're reporting in the effects of COVID-19? So, you know, the first 2 antivirals, they're trying to stop the virus. It's not the same as a vaccine, right? We're going to get to that in a minute, but they're trying to stop the virus from progressing. And the immunoglobulin is trying to help your body boost its immune function, to kind of give you a nice big boost of immunoglobulin to help you mount your own fight. You know, in other words, you know, if your system's going to get overwhelmed and you're going to get sick before you can mount an immune response, getting convalescent serum may help you mount a response before your body can really kick in. And then there's antibiotics, and there are certain antibiotics. There's one that's azithromycin, I think is the one that they're using. And they've found that on its own, it doesn't do anything, but maybe in certain cocktails. And so, of course, the first hot cocktail that was used in was hydroxychloroquine. And the problem with that one is if you have any kind of blood pressure issue or you have any kind of cardiac issue, it's a dangerous drug. And so that's why hydroxychloroquine is not being recommended, because most people who are getting sick, not all, but the majority of people who are getting sick have some kind of other underlying health condition they're dealing with. They call those comorbidities. So I didn't make a slide on that. This is my first time, so forgive me, you guys. I haven't done a presentation like this. You're my test audience. I think I put that one in the wrong spot. So I'm supposed to be talking about prevention and treatment. There's my first slide. Okay, let's go to the second slide. Oh, I didn't do that one. So I have a video I'm going to share with Catherine. I'm going to try to embed it in the presentation on hand washing. And so hand washing, they're all saying 20 seconds and no one's talking about how to do it. And as someone that, you know, did a lot of hand wash training, I thought, okay, this is not that hard. I'm going to stand it up. But basically, the purpose of hand washing is that you use soap and you use warm water, because warm water is more effective on dislodging things on your skin surface, right, than cold water is. And it also helps the soap's behavior. Soap is a surfactant, right, and it likes to break up dirt and lipids. And when you have warm water, you're helping it do that. And the reason it's 20 seconds is because you need to keep some friction going to dislodge things. So yeah, I'll give you, when I give you this, Catherine, it'll have that embedded video. Hopefully it'll work. And the last thing is that everyone should buy a nail brush. If you don't own a nail brush, go get one. When you wash your hands, you need to wash, just rub the brush just gently under your nails as you're washing your hands with lots of soap. And if you keep long nails, now's a good time to trim them. And just as an indicator, if you work in a hospital, they don't actually allow you to have long nails because they know that that's a great place to keep disease, even when non-pandemic conditions. Like, that's not a COVID-19 rule. Okay. So there's a lot of studies going on, as I said. This is the spaghetti against the wall thing, but they sort of fall into some general categories of what they're looking at. And mainly, the disease treatment is trying to see how can we intervene and disrupt the progression of COVID-19 for people that are heading down that track of getting sick, getting sicker, having trouble breathing, going to the hospital and getting on a ventilator. Because once you're on a ventilator, the chances of survival drop dramatically. So the goal is to keep people off of ventilators. So they're looking at all kinds of drug remedies. And one of the top things that happens. So what happens is that when you get COVID-19, the disease triggers your immune system and over triggers it, and especially in the lungs. And you get this thing called a cytokine storm as a typical reaction. There's other inflammatory responses, but that's the big one. And there's a guy out there, his name is Z-Dog, Z-D-O-G-G, I think, and he's a physician, and he's done some decent videos on explaining. So if you want to go out on YouTube and look for Z-Dog, he's actually reliable. I would say a lot of the videos, I thought about doing a myths and what to watch out for sequence here, but in general, a lot of the videos you see out there, even if they're from physicians in general, I don't approve of them. And the reason is, the ones that I've seen posted, the most of them, there's somebody who has some medical training and they're upset about what's going on, and they're diving into a realm that they're actually not trained in specifically. And so they're getting out of their lane a little bit. And, you know, you may have an opinion, but just because you have a medical license doesn't mean you're actually qualified to know that disease state. Most physicians know that, and you won't see most physicians go on and do all these crazy videos, but it's a problem. It's a real problem. There's also a problem. There's a woman who had worked for the NIH, or maybe it was the Centers for the National Institutes of Infectious Disease, where Anthony Fauci is, and she did some great big rants. I don't know if you've seen this on social media. She was fired, and then she came back and stole data, and her publications were retracted because they're full of errors. Anyway, I don't want to go into her too much. They keep pulling her video off, but there's a whole lot of people that watch that video. And Z-Dog actually does a counter to it, and it's pretty good. It's not very long. It's very entertaining. So there, you have to beware. When you're out looking on YouTube and things, you have to beware. Okay, so so in terms of treating the disease, the one that's looking the most promising right now is from Gilead Sciences, which I think began here in Seattle, actually, the company. And they have remdesivir, and that's the most promising one. I think they're into phase 2 trials now. There's some people pushing back and saying that they didn't like the way they designed their study, but they do have some good data coming out so far. And of course, the stock market is going crazy for Gilead at the moment. There are other drugs that they're looking at as like a disease-modifying anti-rheumatic, because again, that's anti-inflammatory, right? And then small molecule inhibitors. Their name always ends in nib, and then monoclonal antibodies. A few of them, their names always end in mab. So anyway, it's just a real light touch on that. I didn't mean this to be much about drugs too much. And for convalescent serum, what's happening is they're doing the trials mostly in hospitals. And they're getting convalescent serum from 2 sources. One is people who who are seropositive or RT-PCR positive and healed for COVID-19. They had a previous, let me put it that way, they had a previous positive test for RT-PCR for SARS-CoV-2, and they're recovered. And then also people who test seropositive from the serology test. They're getting, they collect blood, they basically collect plasma, and then they concentrate it, and that's what the convalescent serum is. And so they're getting it from blood donation centers, and they're also getting it at hospitals from their own recovered patients. So that's great. That's very promising. It's looking good. They still don't know enough to say it's wonderful and it's going to help everybody. So that's the thing about science. You know, we have to admit we don't know what we don't know. And so everyone who's playing by the rules in science is saying we don't know what we don't know. And here's the thing we're seeing, and it looks good, but this is all we know. And in terms of vaccines, there's a lot of vaccine candidates out there, and it's astonishing how fast things are happening. The one to watch right now is Moderna. Most of the vaccines are RNA vaccines. By the time I give this to you, Catherine, I'll probably add on another line about RNA vaccines and just how they work. But Moderna, which is I think a Boston company, is the most promising, and they just finished phase 1 trials and of about 40-something people. and they're going into phase 2 in July, and I'm hearing a little bit more than 800. They're looking for a little bit more than 800 subjects for that one. So if they stay on track, and that's a big if, because clinical trials are notoriously full of boulders in the road. I won't say rocks in the road, I'll say boulders in the road. You're going along very nicely, and then something happens. You know, you have a problem with your supply chain, or you have a bad reaction in your subjects, whatever. A lot of stuff can happen in trials. And assuming everything goes well, they're probably going to be in phase 3 trials. Well, actually, I don't know how they're doing their schedule, because sometimes you can skip phase 3 if your phase 2 looks really, really good and you're on an emergency schedule. But they're saying that they might have vaccine on the market by the beginning of 2021. And that would be unbelievable. That would be totally unprecedented in history. We've never had that happen before. Okay. So that was what I had. I see there's some questions up there in the chat. I'm going to start with those and see what's going on here, and then I'll take your questions. So Roger says, is 70% isopropyl alcohol effective against lipids because of its water content? How are diagnostic and antibody tests different? So Roger, what I'm going to say is straight isopropyl alcohol is probably effective, and it's not so much about the lipids, it's a slightly different mechanism of action. And remember when we had a hand sanitizer shortage and they were saying you can make your own, and they were saying you have to use 90% isopropyl? Well, that was because of the dilution factor. So 70% is fine, because I think when you're said and done with mixing your hand sanitizer, they want you to have at least 60%. So 70% just to put on your hands is perfectly fine. You know, most people don't like putting straight alcohol, and it's also not convenient. You know, it doesn't come in a gel form, right? But that's perfectly fine. You can use 70% alcohol. But it's not specifically geared towards lipids. So next question he asked was, how are diagnostic and antibody tests different? So they are different. A diagnostic test is the RT-PCR, and it's telling you if you are currently or recently infected with SARS-CoV-2. And the challenge with that test, I'll tell you, is that if you have RNA fragments or viral fragments, it can test positive. And that usually correlates with infection, but not always. And that's a really technical topic, but there's some challenge around that, okay? So that's a diagnostic test. The antibody test is different. It's testing your blood to see if you have developed and mounted an antibody response to being infected, okay? And they are different. I did a blog post. I don't know if I sent that one to you, Catherine, or not, but I did a blog post on this call. It was about a month ago. There were people calling for tandem testing. Tandem testing meaning that, you know, even if you have a positive RT-PCR, that they follow up at some point with you and give you a antibody test, a serology test, and that having those two data points is going to give us a much more robust data set. And that's probably true, but we're very, very far away from having the capacity to do that kind of testing. I mean, that would be optimal, right? So to answer your question, Roger, yes. I mean, they're different tests and they tell you slightly different things. Okay, if you know someone was sick with the virus but no longer has symptoms, could you still get sick from this person? So this is fascinating. So my stepfather is a nursing home director in New Jersey, and he got SARS-CoV-2 and got sick with COVID-19. Not very sick, thank God, and he has recovered. So in some states and in some countries, they are saying that if you've been sick and had a positive RT-PCR, that during your convalescence, they want to do 2 additional nasal swabs, and you have to appear clear of SARS-CoV-2 for 2 swabs before they consider you to be non-infective anymore. So he was in New Jersey, and there's a whole lot of, I could talk a lot about what was going on, but they wouldn't, state of New Jersey did not think that they needed to test him and follow up. So they did not test him and follow up. I think by now he's had an antibody test, and he does show that he has mounted an antibody response, but they never did the follow-up RT-PCR. And this is sort of the example of the ongoing evolution of science. We don't really know. We don't think that you can get infected from someone who has just convalesced, but we don't know what that timeline looks like exactly. So that's the best I can say with that. Oh, and Jill Nichols Hicks posted, here's where you can find ZDog. So you're welcome to grab that from the chat. And if you don't know how to grab it from the chat, I can probably add that into the end of my slides. Okay, so anyone else have questions for me? I'm gonna unshare my slides. Okay, how do I do that? Stop share. There we go. Do you have anybody with questions?
So we still have to be cautious by the vaccine come, because it is reopening gradually, but seems everybody feel it's over and seems more relaxed than before. But we still need to be careful, right?
Absolutely. I mean, I think that's an important point. And, you know, people are tired of being locked up, right, in their houses, and they're tired of being home. And for many, they're really, the economic hit is huge. You know, it's a really serious problem. But in reality, we are not over this. And they're now talking on the news. They're asking us to look at history and look at what happened with the Spanish flu in 1918. And saying, you know, once the infection rates were coming down, everybody got excited and went back out eating and drinking and seeing their friends. And then they had a massive second wave, and a lot of people died in that second wave. So we are at risk for that, you know, and it still frustrates me seeing a lot of young people still seem to understand that even though they won't necessarily get sick from this, but they might, by the way, they need to still socially distance and wear masks, because they could transmit to other people who could make vulnerable people sick. So one of the interesting things that's emerging that we don't have a lot of data on is there are 30-somethings, there's a few 20-somethings, there's a whole lot of 30 and 40-somethings, more than you would think, that are getting diagnosed with COVID-19, and some of them are dying from it. And there's some of them have comorbidities and other risk factors. Some of them do not. And everyone wanting to know, what the heck is that about when a 30-something dies who has no comorbidities? And they're speculating, they don't know this yet, but they're speculating it might be related to vaping. So, you know, vape, yet another reason not to vape. If you know anybody vaping, it's a new risk factor. Yeah, and just in case anyone doesn't know yet, King County, as of Monday, instituted mandatory mask wearing in public. So they're requiring us to wear masks, but there's no enforcement. So.
No, they're requiring us to wear masks, but that's just inside, isn't it? Not necessarily outside. They keep all the time?
They want you to be wearing a mask when you are in public, and they think they said in situations where you can't socially distance.
Yeah.
I really think mask really helps. If someone has, and if they have a mask, they don't pass to other people. Helps.
Right, absolutely. You cut transmission dramatically when you wear a mask. Absolutely.
Well, does anybody know what a safe distance is? I mean, considering the fact that the air currents are of different strengths and they change direction when air strikes objects, how can you possibly know what a safe distance is?
Well, that's a great question. And I mean, there's a lot of talk about safe distancing. And one of the unfortunate things we're having happen right now is because all of this is so new, every time somebody has a couple new data points from a study that they've done of whatever flavor, boom, it's in the news, right? So there was something recently that came out that said, oh my gosh, a sneeze can spread 12 feet, right? and then they said a sneeze or a cough. And I was like, really? Well, maybe some people have very, very forceful coughs. Most people do not have a cough with the force of a sneeze. And it can accelerate 12 feet, apparently. So they've measured this, they've looked at the particles. You know, the question is, if someone sneezes 12 feet away from you, are you standing directly in front of them and inhaling? Are you walking quickly by? You know, so there's the likelihood thing, right? And we don't know any of these things. So I would say in general, if you're out in public and you're walking rapidly on a trail and someone you're passing sneezes, it's not good, but the likelihood of you getting infected from that one sneeze is probably not very high. Because one of the things they are looking at also, in addition, is the people who are getting sick may have had multiple exposures. They may have been exposed to coronavirus, because every time you're exposed, it's another challenge to your immune system, right? So the first time you're exposed, you're you know, all the features you have of your body may fight it off. Your nose hairs, you know, the epithelial in your nose, the cells that live there to fight infection and mount an immune response, right? But if you keep re-challenging your system, each time you're re-challenged, you're pushing your immune system a little farther. And this, because this is a novel virus and our bodies haven't seen anything like it before, that's part of why the re-exposure thing is a factor. Does that help?
Well, after reading about the Legionnaire's disease, which was a real problem, it's a bacterial related disease, yes, but it's transmitted in much the same way through ventilation systems in buildings, for example. And so now I worry, okay, I've come in off the street, I'm looking around for people that may be coughing or sneezing, but the last thing I'm thinking about is the adequacy of the air conditioning system, or the central air system, which circulates air from all parts of the building and into all different parts. So, you know, I just wonder, my God, where is it really safe?
That's a great question. And I will say one difference between Legionnaires and this disease is Legionella, which is the bacteria that causes Legionnaire's disease, is a very rugged and robust bacteria, and it would colonize in air ducts. Okay, so one of the problems with that was it would colonize in air ducts, and it would colonize on sort of inadequate filtering systems. And it also tended to like older, less adequate ventilation systems. And so there were some features about Legionella itself that sort of predisposed it to being able to be spread that way. You know, SARS-CoV-2 seems to like the cold and will live on surfaces for 12 months, but I'm sorry, 12 hours. I'm sorry, some up to 12 hours for some surfaces and not others. And they're still studying all of that. They are looking at HVAC systems, and they are looking at filtration mitigations, if you will, to mitigate the spread. And for example, I have a client and they're reopening this week. And one of the things we're looking at is we just got the blueprints from the landlord to look at their HVAC system to see if there's a way that we can put in a HEPA filter at certain points to kind of reduce the load, because they do have a shared air handling system with the rest of the building, right? So it's a thing. I don't think it's the thing, you know, and everyone's looking at different things we can do to mitigate. I think if you go to an appointment, for example, just take your mask with you. You know, take your mask if you're going to sit in a waiting room. You need to do that anyway because you're sitting with people. But in general, just have your mask with you. You know, the only time I don't wear a mask is when I'm at home or I'm out on the trail, you know, or I'm sitting in my car by myself. Other than that, I'm pretty much wearing a mask.
I have a question. Because of supply of short of supply of the masks, I found an advertisement about the mask cellophane cleaning box. You put those stuff in a small box and they kill. and they clean, and you can use mask many times. Is that useful? Is that true?
I don't know anything about that box. It depends on what the box does. So I can say that I'm aware of some solutions companies are looking at with ultraviolet radiation, where you use UV, and it's a matter of intensity and time, and I don't know the answers to that, but I think whenever you see one of these, you have to look at the details. You have to ask them for their specifications and the description of how their product works. And if they're not willing to share that with you, I'd walk away very quickly. Everybody needs to be able to back up what they're saying, right?
Yes, thank you.
Yeah. That's a great idea, though. I mean, but I will say that if you have cloth masks, you can simply launder them, and it will remove the virus.
Yes.
So do you just wear one mask per outing and then wash it? Or, I mean, how often do you launder your masks?
It sort of depends on how long I use them. So I do keep one in the car that I use for my outings, and it kind of hangs over my mirror unless I'm going, and then when I'm going into a store, I put it on. And I'll use that for, I don't know, 5 or 6 trips to the store, and then that one gets washed. Now, when I go out on the trail, I happen to have a mask that I keep where I keep my trail stuff, and I take a mask with me. And depends on how crowded the trail is, right? So if nobody else is out there, I'm not wearing my mask. If I see someone, even at a distance, I put my mask on. So if it's crowded and I'm wearing my mask for 30 minutes or an hour because I'm hiking, especially because you're breathing heavily, you know, then you should probably wash the mask. So, you know, people who are shift workers, when they're wearing a mask, for 8 hours, first of all, you should probably change it within that 8 hours once or twice. And there's a lot of debate about how frequently. That's a whole other thing. But for sure, after a shift, your mask should be washed. That's for sure. Yeah. I just saw a new mask style yesterday. There's a lot of talk about how people, if you wear glasses, your mask will fog up. Well, part of that is about how it fits over the bridge of your nose. So if you're wearing a mask, I mean, I sort of want to start taking pictures of people wearing masks because it's like amazing. A lot of people wear it like under their nose, and I'm like, no, like that's not. You gotta cover your nose. I'm sorry. That's just ridiculous. And then you'll see people, and it's kind of like up to their eyes, or you'll see it's kind of loose. You want it to be conformed to the bridge of your nose and your cheekbones, such that when you put your glasses on, you're putting it over the edge of the mask. So if you don't put it over the edge of the mask, you're going to have this perfect vent where it's going to blow hot air up to your glasses, right? So you want the mask to sit right. I should have brought a mask with me upstairs. I didn't bring it to my office. You want it to sit, you know, just over the bridge of your nose. Your glasses just barely sit on top of it. And then I don't usually have problems. I did see recently a mask made of a stretchy material that has a high particle filtration rate and seems to not, it vents and it doesn't collect steam. So they're calling it an anti-fog mask. A friend of mine happens to be selling it. A friend of mine, a client of mine, actually. So I don't know what the material for that is called, but there are other mask types out there.
So Christine, could you speak to, I know there has been concern, and they talk, because it's already been brought up here, about the droplets that come from our mouth and the difference that happened in that choir that was up north near Marysville here in Washington State, that they were, 60 of them that came and practiced for 2 hours in a room, and how many came down, and yes, you know, can you speak to that, to talk about the differences between that kind of situation and other situations like being in a grocery store and being at a doctor's office?
Sure. Thanks, Jill. Yeah, I think that was a very unfortunate situation. And if you think about, I don't know the configuration of the room they're in, but we're going to assume it was a typical church choir room, right? So it's a room with lots and lots of chairs right next to each other. And and everybody who's there is there to sing, and singing involves a lot of air movement, right? And in fact, lately, singers have been identified categorically, and I don't know that this applies to every person, but they've been categorized as super spreaders, just because of the amount of air that it takes to sing, right? You're projecting a lot of air, right? So you have the fact that you have all these people who are heavy respiration, because singing involves a lot of breathing. They're in a confined space, right? And maybe the ventilation system isn't great. So one of the things about recovering from an infectious disease in a hospital is hospitals have specialized ventilation, and they even have certain floors. The reason they put people with infectious disease on certain floors and not others is they have different ventilation. So they have negative airflow in those rooms with the infectious patients, where it pulls the infected air, if you will, out more than it pushes it in. I don't know if that makes sense, but there's a net negative draft on that room where it's pulling more than it's pushing air in, and that does seem to reduce the aerosol level of whatever the infectious agent is, right? And so I think in the case of that choir, it was the duration, 2 hours, right? It was all those people heavily respirating in a confined space. I mean, it's pretty much that simple. Whereas in a grocery store, it's a much bigger space, and if everyone's wearing a mask, remember those 60 people weren't wearing a mask, right? They were just there, like pre-COVID. But in a grocery store, if you're wearing a mask, first of all, I mean, the ceiling, they know how high the ceiling is in a grocery store, and then think about what their ventilation system must be like, right? Because they have all these other reasons that they have to have good ventilation, right? It's a grocery store. So it's not the same risk to be in a grocery store as it is in sitting in a choir room. I mean, unless you're in there without a mask. And then, I see people all the time, workers. I was just in a place yesterday, and I was like, there they are in a restaurant, working in a restaurant, no mask. So, that you're definitely at higher risk for catching it.
Well, thank you, Christine. This has been really informative and really enjoyable. So I learned a lot, and I think the seniors that were joining learned a lot as well. So thank you so much.